Hello, everyone. I am recording this on September 16th, 2024. This week we're starting to get more intentionally into engagement, that first step of the generalist intervention model. Although, over the past 4 weeks, we've been talking about engagement without talking about engagement. Who we are, how we show up, what models influence us, ethics, how we get to know people. That is all engagement. So we've been doing it a little bit covertly, and now we're overtly doing it. My glasses are dirty. Okay, and we're gonna practice and all that fun stuff. So I'm gonna share my screen here, and we'll get going with the lecture. Okay, so this is a little comic from the New Yorker. If you're familiar, like, oh, I know that type of art. And this one is an image of a seemingly psychoanalyst. Psychoanalysis is done with the psychoanalyst sitting to the side, the person laying down. You're not face to face. There's reasons for it. We're not getting into that. So they're sitting, the psychoanalyst is sitting facing away, and then there's the couch. And we see Humpty Dumpty from the Mother Goose tales, right? Humpty Dumpty sat on a wall. Humpty Dumpty had a great fall. All the king's horses and all the king's men couldn't put Humpty Dumpty back together again. Wow, I remember that. Excellent. And it says, eventually, I'd like to see you able to put yourself back together. Right? So even all the king's horses, all the king's men, they couldn't do it. Just as us social workers, we can't make the healing, the recovery, the restoration happen. We are facilitators of that. We're here to support and support the process, to encourage them to keep going, to hold on to hope when they feel that all hope is gone, or that they're not worth the hope, they're not worth the support. That's what we're there for, so that they are able to put themselves back together. I don't believe that anybody's broken. We might feel that way sometimes, but we all have the capacity within us to figure out where to go and how to do it, and we might need support and suggestions and encouragement and guidance, and that's all great. We don't recover in isolation. We recover as we're connected to others, even if that starts with just the one person sitting across from you, right? I know lunch starts soon. Okay. Sorry, Google's chatting with me. This is empowerment, right? We don't do for others what they can do for themselves. We might have to provide some education and support and guidance, and then they're able to move on. They're able to take those skills and practice them and do it. Okay. Come on, friend. There we go. So, in social work school, you're in all of these classes, and it can oftentimes feel like nothing's connected, or we're not sure how to connect it or anything like that. So I want to present to you this quote from it's a textbook called Inside Out, Outside In. It's psychodynamic work, which is what I'm trained in. And this quote is about how theory and intervention influence the work that we do. Let me take a sip before I read a quote. Every theory is a social construction. By this, we mean that all theories are, of necessity, products of their time and place and culture. No thinker or writer or practitioner lives in a vacuum. Every theoretician is inevitably influenced by all the experiences of their life and therefore constructs theories out of the raw material of those experiences. Many theoreticians find it difficult to acknowledge that their ideas are socially constructed and culturally bound. They often fall prey to the rather grandiose notion that their theories are universal and apply to all people at all times. We believe that no one theory or even any combination of theories can fully describe something as unique and complex as a human being. Even while using a comprehensive biopsychosocial approach, it is necessary for clinicians to recognize that all the theories in the world are not sufficient to explain everything about a person's feelings, strengths, or weaknesses. And when we think about this piece, all theories are socially constructed based on the person, the theoretician, right? The person who's developing the theories. It's based on their lived experiences, the culture they live in, the time they live in, geographically where they are, politically what's going on, spiritually what's happening, whether they value random control trials or qualitative research. Like, all of these things influence how a person, a theoretician, creates theory, right? So I'm gonna leave this one open and nebulous on purpose because there's a social reflection prompt in Canvas that asks you to read this quote again. Oh, I'll copy paste it into Canvas. I forgot to. And what comes up for you? How does this influence your current conceptualization of theory? Okay? How does this, all of it socially constructed, cannot apply to everyone. And yet, we're taught all these different theories, all these different types of interventions, but what is it that actually leads to successful outcomes in clients? This is specifically about clinical work, that's what I'm focusing on right now. When researchers look at psychotherapy outcomes, well, here's what they tend to find. Our little pie chart here. So this big orange piece here, the 40%, is what's called extra therapeutic change. And that's what goes on in a person's life outside of the therapy room. They get a new job. They find a new partner. They fall in love. A new animal enters their life. They welcome a child. They get married. They move. They get a promotion. They feel financially stable. All of these occur outside of the therapy room. They have nothing to do with the therapist. So 40% of successful outcomes in therapy are due to things that have nothing to do with therapy. But those events certainly do boost up a person's self-esteem and confidence and efficacy. They can do things. Look at what they're doing, and it can actually shift their perspective towards seeing a little bit more of the sunshine as opposed to the gloom. 40%, almost half. So then we'll come to our 30%. Our 30% is something called common factors. We're going to look at those on the next slide, but just to say that common factors are non-theoretical. They have nothing to do with any theory or intervention or anything like that. They're essential components for sitting across from somebody doing this type of work. And we'll get into them in a minute. Right? So it's what's going on between the social worker and the client, and also the types of skills that are developed within that type of relationship. Okay, we'll go through that in a minute. So 30%, another big piece of the pie. Now we've got our two 15ers. Our first 15 is techniques. That's the intervention. CBT, DBT, psychodynamic, solution-focused, you name the rest of them. 15%. Not very big, not very much. And the last 15% of our pie is what's called expectancy. Expectancy is what the person thinks will happen and how they will progress as they engage in treatment. Sorta, it's another way to say placebo effect. But I guess placebo effect is frowned upon. The same thing, expectancy. If we expect something to work, it tends to work. So another place of solo reflection for you all is about this expectancy placebo effect, and it's in the solo reflection item on Canvas. It's another one you can engage with. You got some options this week. But let's think about this pie as a whole. 40% of it has nothing to do with you. 70% of it, no. Yeah, okay. 70% of it has to do with you and the client. A lot of it is you. Right? We have 30% of it is these common factors that we'll look at in a second. That has to do with how you show up and how you can hold the space and what it is that the person learns between the two of you. We have this 15% of technique, so whatever intervention you bring in, then we have that 15% expectancy. So expectancy works in a couple of different ways when it comes to these things. So if a person, heard from someone they trust that therapy really helped them, that's expectancy. Ooh, this therapy thing helped them. I bet it'll help me too. So we go in, the client comes in with more acceptance, more openness to the process, which can allow for more to happen. Pretty cool. They might come in and also be like, okay, yeah, therapy is a thing, but my friend received something called CBT. And let's say you practice CBT. Oh, their expectancy grows based on the technique that you employ, right? They're like, oh, that's the thing that worked for them too. Let's do it, right? And then they also heard that therapists are kind and all those things. Hey Google, stop the kitchen speaker. Everything's bananas today on my Google. And gosh, I lost my place. I'm sorry. All right, so therapists are these kind people, and they listen, and they let you feel your feels, even though you might not want to feel your feels, but you know what to expect from that therapist, those common factors, right? So the expectancy grows and grows, which is really good. Yeah, right? So a lot of it does lie on us, but a majority of what lies on us, that 70%, 30% of it is how we're showing up to the room, right? Ooh. Well, 60%, excuse me, I'm not doing math properly. So let's keep going. Just something to think about. My point being, the relationship between you and the client matters so much more than the actual technique or intervention that you use. What happens a lot of the time, people will come to me and say, which one should I do? Which thing should I learn? Which certification? Which training? Blah, blah, blah. Which one's the best? I don't know. These studies, these all have empirical evidence supporting them, which means that they're all beneficial to clients. What matters most is the one that you can feel in your heart and that you feel most passionate about because of that expectancy. If a client comes in and says to me, I would really like EMDR, and I go, EMDR, yeah, I can do it. It's just not my favorite thing. Guess what they're not doing anymore? if they come in, because I don't like, let's say I got the training, I'm like, I don't really actually really like practicing this, right? But they come in and they go, I would like to do EMDR, and I go, great, I'm trained in that. I've seen it help so many of my clients. Let's start talking about what EMDR is, what you already know about it, but all that kind of stuff. It's going to boost that expectancy. It's beautiful. I love it. So that relationship, the way that we share ourselves, the way we show up with them, the way that we express hope and excitement, 60% of that friggin' pie. Love it. Common factors. I'll give you some more context here now. I got that pretty good. Non-theoretical. Common factors are non-theoretical. Regardless of what interventions or what training a social worker or whoever's providing treatment has been through, these things are just common to all of those. And they're essential components for therapeutic success. Lots of empirical research has been conducted on these. So, and I have some notes here, which common factors are all the stuff that happens by just being in treatment. You're just there in that environment. And I say that this happens regardless of the length of treatment, 20-minute brief encounter at the hospital to decades-long psychotherapy, non-treatment, quote unquote, with case management, child welfare casework, psychoeducation groups, supervision, team meetings, and across settings, individual, group, family, couple. Across all of that stuff, these common factors are present. The first column here, we have therapeutic alliance, mitigation of therapeutic alliance, so that means that we have a relationship, me and the client. The mitigation of social isolation. They have somebody who they can tell those things to. Me. They're not as isolated as they were before. Provision of an explanatory scheme. I don't friggin' remember what that means right now. We're going to skip over that. Installation of hope and readiness for change. I feel like those are self-explanatory. Engagement, resource activation, right? Oh, I have this thing. Oh, I have that thing. Oh, I have this thing. Oh, I forgot I have that support. Blah, blah, blah. Effective experiencing affect means emotions. So they're experiencing emotions. Effective catharsis. They're able to express their emotions, and through that they feel better. Cathartic. You feel better by expressing. Problem confrontation. There's a thing. I'm not alone anymore. This person cares about me. I'm able to be emotional in front of them. We can look at what might help, so I can move through these things. Corrective emotional experience. A lot of the time, just in day-to-day life, we might express an emotional experience that we're having, and the person who we're expressing that to minimizes it, dismisses it, rejects it. But in therapy, all the emotions are welcome. You're not too much. You're not needy. You're not overdoing it. You're not dramatic. You can feel the things. Come feel the things. Provision of an explanatory scheme. Those provision of an explanatory scheme, the words just don't make sense to me right now. I'll come back to it later. And then in the second column are strategies and outcomes of the relationship of being in a therapeutic alliance with someone. Desensitization, right? Things don't seem as scary anymore because we're able to talk about the things that we've been avoiding. Mindfulness, we're able to just, I don't really like this word, but we're able to slow down. We're able to pause. We're able to be more aware of what's going on internally and externally and the interaction between those. Emotional regulation, right? We're able to feel the feels, so then we're not as escalated anymore. We're able to come back down. Insight, again with that awareness piece. Assimilating problematic experiences, right? They are part of us, and that's okay. Cognitive restructuring, mentalization, bringing all these components back into our minds and being able to think about them and see how they've changed how we think and how we feel, how we are over time. Behavior regulation, mastery experiences, self-efficacy, expectation, new narratives about self, all beautiful things that happen. What I notice is missing from here is any explicit mention of culturally responsive care. It's kind of like assumed that people are able to do it. Therapists, social workers are able to engage culturally responsively with cultural responsive care. When we don't, all of these things suffer. So let's zoom into that a little bit more, okay? So here are some quotes pulled from, I don't know if these readings are actually in that folder anymore. I don't think they are at all. I can plop them in there. Culturally responsive care depends on us, social workers, whatever discipline, we'll talk about social workers today, right? We're in social work school. Is our capacity to enter the client's subjective world and understand their dilemma as if it were our own. That means we're able to go, ooh, look, a bias of mine. Okay, you're going to go over here right now, bias. Ooh, look, that challenges that perspective of mine. You can go over there right now, perspective. We're zooming in to the person sitting across from us so that we can understand what's going on for them, how it affects their world, and what might help them keep moving. We appreciate every person's capacity to create meaning out of their situation and to generate multiple implications of the event and ideas of what it is not, and perhaps could be. I'm just thinking of a really silly, simple example that has very little to do with, well, I guess there is some culture in it, but, you might be driving down 25, busy road, and someone cuts you off. And they're speeding and they're zipping through the lanes and woof, you get pissed off or whatever the case may be. And the thought is, what a fucking asshole. Not, maybe someone they care about is injured and they're moving as quickly as possible as they can towards that person. Maybe there's someone in the car right now who is having an emergency. Being able to just think outside of how it is the thing affects you and what could actually be going on. It's about releasing judgment, right? We don't get to create the meaning about what's happening in someone's life. We can provide suggestions, and those suggestions get to be wrong. And that's okay if they're wrong. The point is that we are not right. We are not correct. We allow that to come from the client, and we're here to receive it. Another piece, acknowledge the existence of, show interest in, demonstrate knowledge of, and express appreciation for the client's ethnicity and culture, and place the client's problem in a cultural context. We challenge you a lot in this program, hopefully, to be thinking about that piece, especially when it comes to ethical dilemmas and in this clinical work. Race is a conversation in therapy. Bring it up as well as other identities. I will dissuade you from bringing it up if you are not ready to have that conversation yet. That's okay. What's not okay is never being able to have that conversation. If you're not able to have that conversation yet about race and other identities and the difference between you and that person sitting across, the differences between you and that person sitting across from you based on identity and culture, don't do it yet. Practice, 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 practice. The solo reflections that I challenge you with, supervision, talking with peers, talking with family and friends, that is how you practice. Practice having the conversation so that you can bring it in. The reason why I'm saying don't do it if you're not there yet is because you can cause more harm than good. Okay? And if the person challenges you to have that conversation with them, you are allowed to say, I am working towards having these types of conversations by practicing outside of this setting. I will bring this conversation. I'm not ready to do it just yet, and I will bring us back to that conversation when I feel that I have my feet underneath me a little bit more firmly than I do right now. Shows an appreciation, shows that you are learning, shows that you're practicing, and shows that you care about this conversation and that you care to have it in a more contained way. final quote here. 2 therapist characteristics associated with effective service delivery to racial and ethnic minority clients. Awareness of oneself as a racial cultural being and of the biases, stereotypes, and assumptions that influence worldviews. And awareness of the worldviews of culturally diverse clients. Again, that's something that we're challenging here in this program, hopefully. So, when we go back to this, we just think about ourselves as social workers. In order to do this, in order to be in these common factors, in order to be supporting these psychotherapy outcomes, we show up with curiosity, humility, and skillfulness. Curiosity allows us to remain open to the possibilities that are being presented. Humility keeps us open to learning about other people and how they've lived their lives. And our skillfulness, our capacity to listen, our capacity to self-regulate. That's one of our biggest responsibilities in session at any time being a social worker, is to maintain our self-regulation. That doesn't mean that we don't become dysregulated. It just means that we're able to just keep breathing through when we start feeling it, and we're able to keep listening, and we're doing things during the session to keep ourselves grounded. We'll talk about that real soon, actually. And you'll continue to develop all these sorts of skills and how to have these conversations and how to remain open and flexible as you move through school and your internship. That is another place of practice, right? So, how do we improve therapy outcomes? Follow the evidence. Follow what contributes to psychotherapy outcome. Begin by leveraging the patient's resources and self-healing capacities. Emphasize the therapy relationship and so-called common factors. Employ research-supported treatment methods. Select interpersonally skilled and clinically motivated practitioners. And adapt all of them to the patient's characteristics, personality, and worldviews. This is not simply matching a treatment method to a particular disorder will maximize success. All right. Again, there's no explicit mention of culturally responsive care. I don't know what's happening. It's not being considered, is really what it is. How do we do this, right, if we're unaware of our personal biases, the stereotypes we hold, the assumptions, our worldviews, our perspectives, and how we project those onto people? And there is another solo reflection for you to move through that's based on this. How do we know ourselves? And I just want to say this piece of employing research-supported treatment methods. Just because a treatment is empirically supported doesn't make it right or the only one or the only choice. Everything about the person and the environment matters and guides us to select treatments that may be useful. Who they are, how they show up in this world, who surrounds them, what beliefs they have. And if the treatment is not helping, try something else. You might have to refer them out. Maybe they need more resources, support outside of session. Refer them out to someone else who does things differently. You are not the only social worker that they have to have contact with. And if it doesn't work out with you, you are not a bad social worker. I don't know who said, I think this is one that makes the rounds, but I just so agree with it when it comes to this. Banana splits are delicious. Not everybody likes a banana split. Doesn't make them any less delicious, right? You are building your social work foundation, your skills, all that stuff. Not everyone is going to want your services. That does not diminish your capacity to deliver them, what you know, any of that stuff. Banana split, right? Maybe right now I said banana split, you're like, that's gross. Yeah, I love a banana split. And just because you don't like a banana split doesn't mean I don't like it anymore. So continue to hold your confidence, right? You don't suck because it didn't work out. All right. So you'll be practicing some engagement this week. There's some solo reflections you have, small group discussion about culture and stuff like that. So yeah, see you in the comments in the minute paper.